no longer silent, patient access stories.
Being a Black woman physician working in healthcare, I too have to recognize that I work in a healthcare system that has known experiences for creating atmospheres that are not trusting with the Black population.
We're getting loud with Dr. Kasandra White, an obstetrician, gynecologist, surgeon, and health equity advocate. Well, good afternoon, Dr. White. Thank you so much for joining us.
Yes, thank you, Reverend Tammy, for having me.
Do you have any titles?
Yes, I'm an obstetrician-gynecologist with the credentials of MD.
Wonderful. Thank you. Are you a Black woman?
Yes, I am a Black woman.
And are you a breast cancer survivor?
No, I am not a breast cancer survivor.
So you are a Black woman, so that checks one box. You're not a breast cancer survivor, but you are an MD. So that gives you a different perspective around the issue of access or lack thereof when it comes to healthcare and when you're treating your patients. My first question is, what made you say yes to joining this podcast?
I think the title itself holds so much weight, not only personally in my experience of being in situations of being silenced, but also what I not only hear from my own patients, but community members, friends, family, feeling as though they've been silent or silenced in this process of getting access to their care or quality care. And that is why I decided to do this.
Thank you. And thank you so very much for being part of this conversation. I don't know if you know, but I am going to say it to you, how much it means to have a physician that cares and is concerned about the well-being of their patients. Many of the patients that we have spoken with so far all say that they don't feel seen and they don't feel heard when they go into a doctor's office. Mm-hmm. Being a Black woman, what is your experience when a patient comes into your office?
Oftentimes I'm met with different, let's say, responses. Most often they'll recognize that I am a Black woman, but for me, being a Black woman physician working in healthcare, I too have to recognize that I work in a healthcare system that has a historical, not only just in history, but current day known experiences for creating atmospheres that are not trusting for patients. So though I am a Black woman and a physician, I'm still tied to this system. So it's important when I do get initial responses from my patients that see me is that I still have an obligation to make sure that they know that it is their time. Whatever happened before and what will happen after does not matter. That the moment that they step through that door, that it is their time, that I am there to listen. I'm not typing on a computer, but I'm actually building a rapport and trust initially on. And sometimes it's just a matter of listening, meeting people where they are. And I can honestly say, Reverend Tammy, that it's been a range. I sometimes get the, whew, thank goodness. Then on the other spectrum, I've had Black women come in for their appointment and they're like, I don't know who you are. I'm not about to tell you everything. And that's when I know, you know what? I need to spend some time. That means I may need to pull this chair up close to you and talk to you. And sometimes that may mean I need to even share with you what my goal is for this visit, which is to make sure that you get exactly what you need from this visit. And if I'm not able to do it, that I get you to the right either referral systems or individuals to do so.
Are you able to identify when a patient comes in, no matter what their response might be, positive or apprehensive, I'll say it that way? Are you able to recognize some of the historical trauma that we know as Black people we have faced with our medical history, even just doing the one that most people know about, which is the Tuskegee trial. Are you able to identify that type of trauma response, should I say, when patients come in your exam room?
So oftentimes, no, especially when they're new patients, when you're not sure why they're there for their visit. Oftentimes, though, they're registered under one title, they may actually be coming in for another reason. I think what's actually currently lacking in our system is having providers that are actually trauma-informed, providing trauma-informed care, where oftentimes when we're not in emergency settings, allowing patients to voice their concerns, their worries, why they may feel uncomfortable with having an exam. Particularly in my case as an OBGYN, we do pelvic exams. That could be potentially re-traumatizing to a patient who has experienced some sort of sexual assault or sexual abuse in the past. So understanding that I can have an agenda for this visit, but for the patient, this may, if it's not an emergent situation, it's okay to let's build some rapport. Let's get information about your history. But we can also schedule another appointment where you can feel more comfortable, where you can have a support system or an individual with you to make this visit more at ease. So oftentimes we don't know. We don't know what a patient has experienced. Yes, we know about the Tuskegee experiment. We know about Henrietta Lacks. We know about the Mississippi appendectomy, at least I do. Not everybody knows about the Mississippi appendectomies with Fannie Lou Hamer and the sterilization practices that were happening to control the Black population. But there's also those stories on an individual level that we also haven't heard of, which then can come into play how patients move through the system, but also how willing are they to be vulnerable and make that call to go in. Or are they traumatized by a past experience that is prohibiting them from seeking medical care in a timely fashion, which then, as you know, can have effects on survival outcomes if there is a diagnosis of cancer or precancer. So there are huge implications with individuals within the health system. And I have to say, we always say the system, but I also want to recognize that as individuals uphold the system. And we as individuals within these systems have to recognize that though we do follow a standard of care, that every individual that comes through is very individualized and has their own experiences, and we have to recognize that.
Wow, I just absolutely love that, and love that approach and response. Let's individualize the individuals, right? It marries very well with Carrie's touch, as we say that we humanize the Black woman and her experience. We don't humanize the Black woman's experience. We humanize her first as an individual and her experience. Mm-hmm. So what I'm loving about how you're responding is, and what is definitely consistent throughout what you've shared thus far, is the importance of building relationship. It's the importance of, as the physician, kind of investigating up front, why is this patient in here today, regardless of what they were scheduled for? Why are they here today? And am I the right provider for them? And if I'm not, who is, and how can I support them in getting to the resources that they need to get the help and health care that they are seeking?
Exactly.
That's what I'm hearing you say repetitively. And I think it's important because literally 100% of the persons that we have had conversations with thus far have all said at some point they've gone into their doctor's office and they didn't feel seen, nor did they feel heard. Mm-hmm. Mm-hmm. As a physician, what type of authority do you have when a patient comes in and says, hey, I have had 200 days with migraines out of the last 365 days, and I'm checking these boxes, I'm checking these boxes, I'm checking these boxes. Could menopause be a part of it? And the doctor saying, oh, no, absolutely not. That's not what it could be. Well, and then let's just throw you on some medication just kind of randomly. What kind of authority do you as a physician have to even get that type of patient to the right place?
I think it's a responsibility.
That's a whole Dr. White. Now listen, yes, you hold on to responsibility because that's a whole nother topic. That's a whole other piece in this whole thing.
I mean, it's like, okay, so part of my experience as a clinical physician, just where I take care of patients directly, but I've had the experience of working in decision-making leadership roles where we're not only working particularly in inpatient settings, but also inpatient, meaning in the hospital, but also ambulatory or outpatient, the clinic settings. When I look at the ability to move and advocate and feel a responsibility to the patient when they express their frustration with how their symptoms have hindered their quality of life. It could be taking a financial toll, being able to go to work. I don't take it lightly. Responsibility lies in not only my license, but like I said, my responsibility for caring for patients and providing quality care is, of course, number one, make sure that this is an emergent or what we say acute situation that renders medical attention in the emergency room. And that requires listening. That requires asking questions. That requires making sure your support staff is taking the appropriate vital signs and recording the vital signs so you can review all that medical stuff. And then, importantly, is to get that history from the patient. How long have you been experiencing this? What have you done? Who have you seen for this? How has it bothered you? I don't think we really ask that question enough. What has this done for you and your quality of life? And then from there, we look at, okay, what type of resources do we have within our system that could potentially lead to improvement of quality life for this patient and their symptoms. So does that mean ordering labs? Does that mean making sure that the medications that they on are appropriate? Does that mean reaching out to a specialist? All those things take time, but you also think, like, how do these systems support that? Right? How do these organizations, when appointments are only sometimes 15 minutes? So for most often, I feel like physicians and providers, when I say providers, we also have nurse practitioners, physician's assistants that will see patients, that they want to do all those things. But is the system supporting that? So what that means is oftentimes that may mean we run behind, that next patient may not see their provider until later because this particular patient needed more time. And I'm very transparent when it comes to caring for patients that I've been seeing long term and also new patients, that I often tell them that sometimes I run late. And that just means, you know, I would do the same thing for you if need be, that if someone needed extra time or you need extra time, that's just what it's going to take. And oftentimes being voice to management, you know, I know I've experienced where my support staff leaves exactly at 4:30 p.m. I'm still seeing patients at 4:30 p.m. The work does not stop. It won't stop until the last patient walks out the door. So oftentimes vocalizing that is also my responsibility, to letting management and leadership know. I need to make sure I have the support team also available, because it's not just me. It is totally about the patient. It's being able to give the patient their time and appropriately care for them in not a rush manner where they feel like they've left and have not been heard. And that's where I bring up, Reverend Tammy, the responsibility not only to the patient, but also the responsibility to make sure that I am letting those who are in decision-making seats, those who do have the ability to make the calls, to make sure enough support teams are available if the clinic runs over.
You're saying so much, when we talk about access issues. For me, it's about retraining and restructuring the entire system. And this question may not be very fair. And so feel free to say, well, I decline to answer that. But do you think it's possible to retrain and revamp, reorganize, restructure the system?
I am a believer that anything is possible with the right leadership, with the right management teams. If there are systems that understand the importance of accountability and responsibility, and keeping in mind that what we all are here for, every single individual, particularly staffed, employed by the hospital, is that we're always there for the patient. If we can center all that, then I do believe the systems can change. I think there's different levels to approaching access to care, from an organizational level, systems, to the provider level, in terms of how we're hiring, turnover, structure, workflows, utilizing staff to their highest ability of their license. I think when we have so many of those pieces in place, that is where access can be improved.
So where do we start?
I think until we start, and I say we because part of the healthcare system, we recognize that there are gaps and deficiencies in ways that aren't meeting the needs of the community, then that is when we can start creating those solutions, right? Let's look at the social economic status, the education level. Let's look at the breakdown, the geographical breakdown of our communities, and let's make sure that our system, and I may be talking as though, oh, this is easy. No, I know there's many layers and things, but this is just how I start to compartmentalize what are some ways at which what we have now can change. So looking at making sure the insurance profile meets the needs of our patient, our community. We're making sure that from a systems also standpoint is addressing compliance issues, right? And when I say compliance issues, I think about this term EMTALA. And I'm not sure, Reverend Tammy, if you're familiar with EMTALA.
I am not. And that's one of the things I love about talking with you. I always learn a new term. So please inform me.
So it's EM as in Mary, TALA. And what it stands for is Emergency Medical Treatment and Labor Act. And it is a compliance measure for all hospitals. And it is absolutely required. But when we talk about access, we think about, again, our hospital systems and organizations compliant. And the reason why this is actually important, because right now, there is a drive to make sure that hospital organizations are compliant in this because they're finding that they're not. And what it is it ensures that the public has access to emergency services regardless of the ability to pay. And that not just is the emergency department, but for me as an obstetrician-gynecologist, that also involves labor and delivery triage. And so they're finding that many hospitals are not compliant. If they're not compliant, how are we ensuring access to our patients? So that's why I actually brought that up. And that's why I bring up that there are certain pieces to just even the systems and organization level that are so profound and needed and are focused even right now to remedy some of the issues we're seeing around access. And then I think about on a provider level, staffing issues, staffing shortages, needing travel nurses, travel doctors on urgent basis who aren't familiar with the particular hospital organization, but just having a body there. But we think about if there's staffing shortages, how that can shift access away from patients. And then we think about representation. The question you asked me earlier about, when patients see me and I'm a Black woman, representation, right? Representation is important. Data recently showing benefits for being cared for Black patients, cared for by a Black provider, increases their life expectancy. And so Black physicians in the United States make up less than or about 5%. Black women physicians, about little over 2%. And like me, a Black woman physician who happens to be a surgeon, I make up less than 1% of the active physicians in the United States. So you're not seeing the representation. And there's a lack of, and of course you're not going to have a hospital staff that is exactly like what your community demographics look like. That's where the empathy component comes in. That's where the professional responsibility, that is where the providers are grounded by Hippocratic oath to follow, to do no harm. All those things that we vow to do are so important.
We want to pause for a moment to thank our platinum partner, Amgen. Amgen has been a consistent partner who not just talks the talk, they fight hard to illuminate voices and experiences of diverse patients. We're truly thankful for such a beautiful partnership. This conversation is also activated by Genentech and Change for Sean. Thank you to all of our partners. Part of me wants to open a can of worms that I don't know that we have enough time to get into, because when you talk about staffing to be able to accommodate the number of patients that they are seeing, that any physician or healthcare system is seeing in a day. And what we know is that COVID did a number on the entire healthcare system that was already struggling. You and I could have had this current conversation in 2019 and it could stand as we are having it now.
Mm-hmm.
Throw COVID into it. The impact of COVID on physicians with burnout, it's overwhelming. I was on a Zoom call with a patient that was meeting with her physician, and the patient could see that the physician was not having a good day. And the patient asked the physician, "Are you okay?" So when you talk about burnout, and then you add in the impact of COVID, can you just share your thoughts on just that situation?
That's another layer of strain of the system. And we saw so many effects of what COVID did in terms of patients seeking care. Right. In a timely way, waiting at home and their condition worsening if they were affected by COVID. Mm-hmm. I remember the second wave, at least 6 weeks straight, we had 100% of patients COVID positive. And we also think of staffing that were affected by COVID, either personally or their family members, and had to not be at work. I mean, I think about just even the families not being able to come in and see their loved ones, even in their last days of life. On a personal note, because I work in a community where I have a lot of family and friends, and because they know I work at this facility, that oftentimes they would call me asking if I'm at work to go see their loved one that was hospitalized. And I can honestly say there was a few times that I actually had to tell either a friend or their family who was inquiring about their loved one that they had passed. That will stay with families for a lifetime. I don't think there's anything that can ever make that any better. But even outside of COVID, there is still a disconnect that I think that exists, that I see between the communication to patients and their loved ones. Yeah. We have lifted visitor rules now. We don't have that constraint like we had anymore, but I'm not saying that we're giving that enough. If we're going to build that connection, if we're going to build that trust, even in the hardest of these situations, giving bad news, we have to think about it. How would we feel if it was us, if it was our family? Sometimes we just want to know, just say.
I want to shift the conversation just a bit as we begin our descent in this conversation. What recommendations do you have to empower patients when they walk into a doctor's office and they are not heard? You shared a lot again about empathy, getting to know the patient and all of those things. How do we empower a patient? Because it's a two-way street. You know, a lot of times patients walk into a doctor's office and think that you are God and or miracle workers and that they have no responsibility in that room.
Mm-hmm.
But the objective, at least from my perspective, is that we need to get to a conversation where there's clear understanding so that we can have shared decision making in this patient's care.
Mm-hmm.
What recommendations do you have for the patient to prepare when they walk into to see you?
Programs like Carrie's Touch, why they're so important is because Carrie's Touch holds a wealth of information, but also access to others who have experienced going through the health system, navigating through the health system. So leaning on your peers, leaning on family members, even though each individual's totally different, but there may be something there that it's okay to ask. It may not apply to your situation. Ask the doctor and let them tell you their reasoning why or why not it does not apply. Yes, we always say be prepared to ask questions. Sometimes we don't know what questions to ask. I think it's okay to use accredited resources on the internet. Resources like in Carrie's Touch to reach out, to get information, certain professional organizations to do your research to find out what are risk benefits of certain treatments. So that way, when you do go to the provider's office, be ready to ask those questions. Doctor, why is this happening? When can I expect it to get better? Who's going to follow up with me? What do I need to do? When do I need to do it? How do I need to do it? So some of those just general questions, who, what, when, where, why, and how, is how I actually talk to many of my family members. Yeah, they have me in the family to ask questions. But, you know, sometimes, like, even if you don't know the medical terminology, that's okay. But we definitely know how to say, why are you offering me this? Do you offer this to everybody? And if something is declined, and I myself have had to experience this personally, where I have been denied some sort of testing, I have actually said, are you documenting this? And my, how that changed the conversation. And it's also so imperative that patients express how they feel. I think we often forget, like, tell the doctor, tell them, I am worried. My family is worried. And if you can't do it, then I'm going to go somewhere else.
Absolutely. I love everything you said. And shameless plug here, and I don't know if you have this, Carrie's Touch, since you mentioned us. Thank you very much for the shout out. Carrie's Touch has an app. We have a part that's called Take Control and Before You Go. And in the Before You Go feature, it really is doing a check-in with the patient so that the patient can say, what is your understanding of the purpose of this visit? Right now, what are the top 3 things you want your medical team to know? What are the top 3 questions you want to ask your doctor? You can have a whole list of questions, but the truth is most doctors are not going to extend that 15 minutes. The intention behind this app is to help patients maximize their experience in their doctor's office. I bring up our app because it's a resource that can help patients go through those 5 W's and
I love it. Yes, I love it. I love it.
We go in there and we say, this hurts. Well, what hurts? And when did it start? We know the questions the doctors are going to ask. Y'all all ask the same questions because you're doing what? Going through the 5 W's and the H.
Resources like that, so necessary. Absolutely necessary.
Yeah. Is there anything that you wanted to make sure you share with our listeners that we haven't talked about yet?
I would hope that there is a day when the burden of needing to not only process being told of a medical condition or a diagnosis, but also needing to do your own research, to create a own plan when you go. I hope for the day that is not necessary. I know for me, I will go beyond that time visit, but I also do know that's not going to happen across the board. And at this point in time, until we have some system changes, until we start looking at the structure of our staffing, ensuring that providers are going through their implicit bias training and have that as something ongoing, not just a check the box, that eventually one day that we can get back to providers seeing their full responsibility in giving the information necessary for patients to make the right decisions for themselves. It truly, it bothers me that the onus, it's gotten to the point where patients have to do this full-on search to figure out what's best for them.
Yeah.
But rightfully so. I have absolutely learned in my practice, patients know their body. They do know their body. Share that. If you know something's not right, stand on that and don't let up. But I just hope for the day that, again, providers can get back to the place of seeing their full-on responsibility to patients and their well-being and their health outcomes. I have to put a plug in about a legislation bill. And this is around a bill that passed back in 2022, January 1st of 2022, and it's called the Silence No More Act. And this is because of the topic, the silence. When I hear patients complain that there aren't Black providers, or I see startup companies creating resources or directories to find Black physicians, I think about the experience that also physicians who are Black experience in these spaces in terms of harassment, discrimination, retaliation, often sometimes speaking up or advocating for their patients, finding that they're faced with resistance or some sort of retaliation in these settings and often will lose providers. And this particular bill was proposed by the author, Senator Connie Levia, here in California. It restricted employers for enforcing NDAs or non-disclosure agreements around employees who had experienced some sort of discrimination, harassment, or retaliation in the workplace, whether that's race-related, age, disability, ethnicity, origin, basically civil rights. And that no longer can employees or employers silence those employees who either leave their job under some sort of severance or settlement, but can no longer be silenced. And if we're in a place where we have systems, not just hospital systems, but across the board where experiences of racism or some sort of discrimination can be experienced. But for this sake of the conversation, we'll think of the patient concordance, why we're not seeing Black providers in spaces, right, or why we're losing it. Then we think about what that culture is keeping and the secret that they're keeping. And are they really wanting to become inclusive? And so when I think about how powerful this particular bill is, because also we know Black patients do better with Black providers. I would love to see them come out with some of the evidence based showing across the board the difference in care. What it does by silencing these experiences, these voices of people that actually are advocating for patients within these systems, is it maintains a culture of secrecy, and it doesn't hold these hospital systems accountable or respect or justice for patients. So that is why I bring it in. Not everybody sees how this ties into, but it plays a part into how we are still seeing disparities in care of our patients. And it's because we are finding that even within these hospital systems, they have been silencing many of the voices who have been very vocal on the need for change. And now that is no longer. So
I'm 100% on board, and thank you so much for sharing that part with me. I was furiously looking up something, but it reminded me of the African proverb that says, until the lion tells the story, the hunter will always be the hero.
Ooh, that
Right?
part.
That part right there. And so that's what this bill reminds me of. It says that no, the hunter can't tell my story because the hunter doesn't have my experience. And so, and then you can't silence me, right? So that the hunter can provide this false portrayal of the experiences that are happening. I'm always so honored and grateful to share space with you because you bring such a level of wisdom and insight based on your lived experiences, and these are the stories that aren't often told. And Carrie's Touch, we do what we do the way that we are doing it because these stories have to be told. What we know is that if we keep telling the stories, at some point, whether they're banned in schools or not, people will know that the story is different than the one the hunter is telling.
That's right. Right? That's right.
Dr. White, thank you so much for being here.
You got me ready now.
Just give me your final thought to just summarize, however you would like to summarize your sharing. Just give me your final thought on the topic.
I see so much power in the voice, and I am grateful that you have created this. I thank you for allowing me as a provider to come into this space, because even sometimes as providers, we can be silenced. And if we are on a path of impactful change, then it's time to be loud.
This is what I'm always, I said, there is power in our voices. Let's get loud.
Let's get loud. This ain't J-Lo, honey. But
all right, let's lighten it up before we close out. Let's lighten it up. Okay. Tell me your preference, day or night?
For what?
We're gonna move right on past that, because actually it could be day and night. But who's asking the question?
I'm a morning person. I work. Yeah, I'm a morning person. But as a clinician, I've been on call in the middle of the night all day. So yeah.
Right. Okay. Let's see if this one's any easier. Chocolate or vanilla?
Oh, chocolate.
Okay. What type of music do you like to listen to?
Oh, depends on the mood. Today was R&B day.
Nice. Breakfast or dinner?
Breakfast.
Okay. And last question. What brings you joy?
Ooh, my people. That's it. My village.
Yes.
We run tight. So, yeah.
I love it. You are exceptional. Thank you so very much.
Appreciate you. This was awesome.
Dr. Kasandra White, wow, what can I say to you but thank you, thank you, thank you, thank you. Keep fighting the good fight, and thank you for your courage to share your story with us today. Thank you to renowned virtual photographer John Keatley and his incredible team. A special thanks to Photos by A Love LLC, April Jones, Retouch Artist, and to the dedicated Carrie's Touch tribe for your unwavering support in helping us create stories that heal. And another big thank you to our platinum sponsor, Amgen. For more information about these stories and other survivor support and advocacy information, visit us at our website at www.carriestouch.org.